All righty, we'll get going then. Hello, my name is Martin May. I'm a transplant nephrologist at Mayo Clinic and delighted that you all could join us today for our webinar, Guiding Your Dialysis Patients Through the Kidney Transplant Process. We've got a team that will help present some of this information, and we'll introduce each of us as we're ready to give our talk. But I will get started, and Pat, if you could advance the slide. So this is our campus. High on just below the skyline is the Atlantic Ocean. So we're only a few miles away. There's a barrier island that you can see on the left, just beyond the bridge. That's Ponte Vedra. To the north is Jacksonville. The bridge crosses the Intercoastal, and Mayo is just across the street from some housing that has access to the Intercoastal. This shows a picture of our campus. That's a new parking garage there on the left. That glass enclosure is a beautiful new atrium, has some restaurants, nice areas for patients and their families to relax. On the right of that structure is the new emergency room and some new clinic offices. And what is not shown is the steel girders of 5 new floors on this structure on the far right, which is the Mayo Hospital. So they're got 8 floors now, and they're building 5 new floors. There's multiple other new buildings going up on campus, so it's certainly a growing medical center. Next slide, please. So we're a busy program, got a lot of people to help manage the patients. I'm one of 7 transplant nephrologists. We have an 8th joining us in January. We have 7 transplant abdominal surgeons. So not only do they do kidney transplant, they also help us with pancreas transplant. And they're the surgeons that do all the livers here because we're a big liver program also. To help manage this load, we have wonderful advanced practitioners. 8 of them are in the hospital rotating on those 2 services. And then we have 3 in the outpatient setting managing clinic load there. And then our coordinators divided up between pre-transplant living donor and post-transplant coordinators, and a wonderful dedicated team of social workers, pharmacists, dietitians, psychiatrists, infectious disease physicians are part of our team to get our patients properly evaluated and then to deliver the care they need after the transplant. Next slide, please. So we're a relatively big volume practice, a lot of growth over the past 5 years. So each of the last 2 years, we've had a little over 220 kidneys. That far right column, 139, is increased by 2. We did 2 transplants yesterday, so we're up to, I believe, 141 kidneys at this point. Next slide, please. Our success is excellent. So although it looks like the observed patient survival is way above the expected or national average, note that it's roughly 96.9% versus 96%. So we do a little bit better numerically, but not statistically better than the nation or what is expected for our team. But we're proud of this number. So this is what we have as an outline to help guide you with your patient. We'll talk about the referral process, then move to evaluation. We'll talk about what selection is, and then we'll review wait list management, and finally cover transplant and post-transplant care. The main focus here is providing information that you need to help care for your patients. And of course, we want to learn too. So if there's a way that we can deliver information, deliver care, deliver records, we want to hear that feedback also. We're always looking to improve our process. So we'll start with the referral. Can we have the next slide, please? So when do you refer a patient to get transplanted, in general, they have to have advanced kidney disease. So recall that you cannot gain time on the wait list until your kidney function or glomerular filtration rate is 20 milliliters per minute or less. So most people hear not so much the units, milliliters per minute, they hear a percentage. And the percentage is based off that most normal kidney function is around 100 milliliters per minute. So listing requires 20% function or 20 mils per minute or less, but we will evaluate patients with GFRs in the 25 milliliter per minute range or less, anticipating loss of function so that they get the benefit of time on the list as early as possible. We will look at people up till age 80. We actually did a transplant in an 84-year-old in the spring of 2022, and she's done well, but that would be the exception. And once you hit your 70th birthday, particularly once you hit 75, we're much more particular about your health, and you have to be more perfect to be on our list. We will list people for transplants with BMI generally under 40. We strongly encourage anyone that has a BMI above 35 to consider bariatric procedures if they've had no luck with the usual ways that we try to lose weight, because that's very difficult. And it provides such a huge medical benefit to the patient. If they qualify for bariatric evaluation here at Mayo, we'll make that appointment. If they don't, then we encourage them to seek care locally. Weight loss can markedly improve outcomes, reduce postoperative complication, reduce postoperative diabetes, hypertension, sleep apnea, et cetera. So that's our guideline, though, 40 or less. And then be aware if your patient has some chronic infections such as hepatitis B, hepatitis C, or HIV, we're more than willing to work those patients up. Hepatitis B is a manageable infection. Hepatitis C is now curable. HIV is also manageable, and they do well post-transplant. So to review the next bit of the referral process, I'm going to hand you over to Natalie, who will take over from here. Natalie.
Thank you, Dr. May, and hello, everyone. My name is Natalie Ball, and I'm the operations manager for the kidney transplant program at Mayo Clinic Florida. Before we dive into the referral process, I do want to make sure we note that if you have any questions, feel free to submit them through the Q&A. We will plan to take any questions at the end, so feel free to submit throughout the presentation, and we'll be sure to circle back at the end. So let's talk a little bit about the referral process. So from a referring provider clinical staff perspective, there are several different ways in which you can refer a patient to us. The first is CareLink, and we'll spend a couple of slides going through what CareLink is. You can contact us. We have our phone number listed there. Our operations are Monday through Friday, and it is 8 to 5. Sorry, that is a typo there, but it is 8 to 5. You can also fax any referral request to us via that number there and include any medical records that you have. From a patient perspective, they can, of course, also contact us via our phone number during business hours, but they also have the option to submit a request via the online form, and the link is listed there. Next slide, please. So what is CareLink? So CareLink is a tool that will help any provider or clinical staff refer a patient to Mayo Clinic. It's a secure online portal that not only allows you the ability to submit a referral, but you could also submit any records or imaging to us. You can see the progress of your referral, and you can view any upcoming itineraries that we have for the patient. One other thing to mention is you can see any notes or records from the Mayo Clinic care team. So there's a lot of really cool features that you have access to by being or having an account with CareLink. So who has access to that? You can see it is not an exclusive list. Anyone, any provider, clinical staff, as long as you have an account, can use CareLink and refer any patients to us through CareLink. So that clearly does include our social work colleagues. How can you sign up? We've attached the link there, so you can use that link to create a CareLink account. I do want to mention it does take 7 to 10 days to process your request and verify the count. So don't be alarmed if you don't see an immediate response once you do submit that request, but just know it could take up to 7 to 10 days. And then at that point, you will receive an email from us asking you to activate your account. So just be on the lookout there. And then we've also included on the far right there some contact information if you have any trouble with CareLink. At the bottom of that slide there, you can see a link to a video that provides a really, really great introduction of what CareLink is, what the platform looks like, and what some of those features are. Next slide, please. And I'll go back, yeah. We've included a screenshot just so you kind of get a sense of what it looks like. But like I said, that video will go through in detail kind of the different tabs at the top there, how you can navigate this platform and what some of the features are. So what can you expect from the referral process on our end? So once we receive your referral requests through any of the platforms that we've mentioned earlier, our Mayo Clinic Florida scheduling team will contact the patient to complete our intake process. And that does include gathering or collecting any missing information we don't already have as part of the referral request. If we haven't already received it already, we will send a disclosure form that to the patient that notifies us that they approve to send any medical records to our institution and that they're okay with that. And then, of course, if there's any missing medical records that we don't have, we'll request it at that time as well. So once that intake process is completed, we will begin with the medical triage portion of the process, which involves our nephrologist reviewing that criteria that Dr. May mentioned earlier and make sure that there's no significant contraindications that might suggest the patient's not a good candidate for transplant. While that medical triage is going on, we'll also be doing financial triage. We have a really fantastic team called our Transplant Finance Center that will review every request and make sure that the patient has insurance coverage that extends to transplant benefits before moving forward with the evaluation process. Once those two items are approved, then our scheduling office will contact the patient and offer an appointment. One thing I'll mention with CareLink, if you submit a referral via CareLink, you'll be notified automatically through CareLink that the patient's appointment has been scheduled. So that is kind of a nice feature if you were to submit a referral through CareLink. Next slide. So how can you assist with the referral process? So the first and foremost is just make sure we have all the records that we possibly need. That could include a recent history and physical, any recent labs, imaging, etc. For those that are applicable, we also need the 2728 form. I'm sure many of you know what that is, but if you don't, it's that form that provides documentation that the patient has end-stage renal disease, when the patient started dialysis, what facility they're receiving dialysis, and the type of dialysis. Obviously, as Dr. May mentioned, that start date is used when we're listing the patient on the transplant wait list. We mentioned the disclosure form, so that's really important to have. We can't move forward with scheduling the patient until we have that on file. And then making sure we have any updated insurance information. We will review that on our end, but just every bit of information we have up front helps expedite the process. Next slide. And I will pass it off to Rhonda, who will talk a little bit about the evaluation. Rhonda, you're muted.
There we go. Can you hear me? My name is Rhonda Rose. I'm one of the kidney transplant coordinators at Mayo Clinic Florida, and I wanted to just give a quick overview of our evaluation process. As you know, centers can set up their transplant evaluation process however they choose. Some centers do them in clinic like we do, and others you'll go in for like a day of appointments and then do all of your testing locally. We have found that by doing the evaluation at our clinic that it can shorten the wait time from evaluation to listing. We did, and we've also created a couple of pathways to kind of simplify the patients and reduce their time on clinic. So we've started allowing patients to obtain their cancer screening at home, and we've started offering semi-virtual evaluation pathway. That kind of started with the pandemic when we learned that we had the opportunity to start doing education classes and some of our consults virtually. So when patients come, they actually will see the entire multidisciplinary team and be offered educational classes and then have the testing. Next slide. So all appointments technically could take up to a week to be performed on campus, but now with the virtual option, we're actually seeing 2 to 3 days. As you know, patients that are older typically require more testing, and if they're diabetic, but if somebody's like a 28-year-old IGA, we can get them in and get them tested over a couple days, and then they can do the additional consults and virtual appointments at home. This virtual ability has been great because it reduces the patient's time in Jacksonville, therefore reducing their hotel and travel expenses and time away from work and their families. Next slide. So this is kind of a snapshot of what's involved in the evaluation. So when the patients initially come in, they are provided with written materials that, since CMS require us to give us. It's a packet of information about kidney, pancreas transplant, some UNOS guidelines, time transfer information. They also watch an education video, and they also have the virtual classes. They also kick off their evaluation with a transplant coordinator, and we're on the phone with them for about 45 to 60 minutes, providing education about the evaluation process, reviewing their schedules, making sure they understand what the plan is. And then during the evaluation, they'll meet with a transplant nephrologist, surgeon, social work, nutrition, pharmacy, and psychiatry. As you know, this algorithm that we set up for the initial testing doesn't mean that there won't be any additional testing required. If we have an abnormal scan or an abnormal test, then further consults may be required, and we can't always do that at the time of transplant. So we will try to give the patients the opportunity to do those at home locally, or we'll set them up for them to come back here. Patients that are from out of town, we do arrange for dialysis to be done here. And patients that are local, we just work around their schedules. And that's it, I believe, for the evaluation. I think next is psychosocial with Pat.
Okay, so the social work team here, we really do a thorough assessment of our patients. We're looking specifically at factors, excuse me, that can affect their transplant outcomes. So we're looking for social support, financial issues, mental health issues, any personality traits or disorders. We're looking at adherence. We're looking at alcohol, substance abuse, and smoking. And we're trying to gauge any inability or unwillingness to understand the need for transplant follow-up adherence. We look too at family structure so that we have some idea of what other available support the patient has. We're looking at what their interests and their hobbies are and what motivates them and kind of how they cope when they get stressed. And we're doing all that because when that individual patient starts running into issues, if they do run into issues, we kind of need to know how to help them get out of that funk. So we try to get enough information on the front end to kind of figure out how to do that. And then we just need to be able to understand what the resources are in case we need to assist the patient, regardless of what our plan was in the beginning. So as far as caregiver support, we do require that patients have a primary and a backup caregiver in order to be listed here. We strongly recommend that the caregivers attend the evaluation appointments with the patient. That just helps them get some education and they're hearing it at the same time with the patient. If the primary caregiver is not able to be here for the social work appointment, they are required to contact us to be vetted. Patients are not cleared for listing until we have spoken to all the members of the primary caregiver team. And primary caregivers are required to attend an education class, a caregiver education class, but that is offered on Zoom and it's offered 3 times a week. So what are we expecting the caregivers to do? So the first thing is, while the patient's in the hospital, we're looking for them to be with the patient and get the education from the team during the daytime hours. After they discharge home, they're required to do all the transportation because the patients aren't able to drive. They're usually managing the appointments and the medications with the patient. They're helping take those vital signs every day, and they're coming with the patients to all the appointments. They sometimes have to do things like wound care or help with insulin injections too. So some financial considerations and fundraising rules here. Patients who do not have the financial means to pay for their post-transplant expenses like the medications, the relocation, may be required to fundraise prior to being activated on our list. The fundraising goals are unique to every single patient that walks in the door here. It depends on their insurance, on what kind of discretionary income they have, what kind of savings they have, and what their expected expenses are based on those things. If they are listed with a fundraising goal, our social work team reaches out to these patients every 90 days to follow up, and we try to help them meet their goal. We give them resources to do that and encouragement to do that. Help Hope Live, National Foundation for Transplant, and Georgia Transplant Foundation are all nonprofit organizations that can help our patients do that fundraising. All of you are very familiar with the American Kidney Foundation funding. Dialysis patients can apply for those HIP grants through AKF. Often, you guys are helping them pay for their Medicare Part B premiums, their supplements, or even their COBRA or secondary coverage. Once they're transplanted, AKF funding ends the end of the calendar year for these patients. And they are able to extend that if they're transplanted in the final quarter of the year, it may be extended for another year. And that is what we're seeing here. Patients have to take over their grants management system account. So it's good for you to share with them their PIN numbers. They have to revise their status to be transplanted within 3 months of their transplant. And then they need to be submitting their own documentations after transplant. We're not going to be seeing them the way you guys see them. If a patient receives that AKF funding and they can't afford the premiums after transplant, they'll need to fundraise for that cost. So we do have them fundraise for some of that. This is the tool that we use to educate our patients, and it just categorizes the expenses that they're going to have and lets them see what their available resources are against that. And we do offer that financial basics class too, and there's a recording for that already out on our YouTube channel. So at this point, I'm going to turn it over to Erica, who's one of our transplant financial coordinators, who's going to talk a little bit about the insurance stuff. And thanks, Erica.
Good afternoon. I am in transplant finance, and what we do is we verify benefits and eligibility prior to patients being scheduled for a workup. So we make sure that we have the correct benefits for them. And any referring programs can feel free to call us anytime. If you have a patient that you want to see if we can evaluate them for transplant, we can tell you if we are able to work with the insurance or not before you submit the referral. Our number is 904-956-3745. We're open 8 to 5 Monday through Friday. So if you want to give us a call and see if we accept the insurance prior to sending the referral, anybody that answers would be happy to tell you if you can submit it. We do have a finance phone call with every single transplant patient. During that call, we ask that they please make us aware of any changes to their insurance so that we can make sure they can continue to follow up at Mayo Clinic. And in turn, if we are advising the patient their current benefits are not, we're not able to work with them for transplant, we give them a list of what we can work with and encourage them to reach out to their current physicians before they make any changes, because we don't want them to change their insurance just to come to Mayo and then not be able to see their other physicians outside of Mayo. We make them aware of their ESRD coordination period, so that when we call them, if they haven't enrolled in Medicare yet, we try to call them a few months early, tell them you need to go ahead and enroll in your Medicare because it will be primary as of this date. We want to make sure that there's no billing issues with Medicare supposing to be primary and another commercial insurance is secondary. Next slide. When patients begin dialysis, they become eligible for Medicare due to end-stage renal. There are a couple other rules about being eligible for Medicare due to end-stage renal. There's the work credits and things of that nature. When it comes to being eligible for Medicare, there are some patients that they don't have enough work credits and they are not eligible for Medicare. There is a program where they can pay for their Part A, which is usually free. There's no charge for Medicare Part A for the patients that meet the other requirements for Medicare. When you transplant with Medicare as a primary insurance, their immunosuppressive drugs are covered under their Part B, their outpatient coverage instead of their drug plan, and that happens for the remainder of their life. There is a bill that just passed that makes Medicare always cover the immunosuppressive drugs under their Part B. Okay, let's see. So once a patient transplants, they will be eligible for Medicare for 36 months. After the 36 months, Medicare will drop off completely or it will become secondary again if the patient has it for another reason other than end-stage renal. And then when the patient turns 65, their immunosuppressive drugs will still be covered under their Part B, as long as they had Medicare active at the time of transplant. Next slide. Open enrollment for traditional Medicare runs from October 15th to December 7th. They can decide to just continue with their traditional Medicare or enroll in a MAP at that time. And it will be effective January 1st. Medicare Advantage Plan open enrollment is January through March, the end of March, and it will become active on the 1st of the following month after they enrolled. So if they enrolled on February 23rd, it would be effective on March 1st, and so on. The Marketplace open enrollment is November 1st through December 15th, also effective on January 1st. If they have an employer coverage and they lose their coverage, they would have a open enrollment period for their marketplace plans if they want to enroll in a marketplace plan if they lose their primary coverage through an employer. If the patient has to pick up Part B, if they only enroll in Part A when they become eligible, the Part B enrollment period is January 1st through March 31st with a July 1 effective date. So we try to encourage our patients to enroll in Part A and Part B when they become eligible because we don't want Part A to be primary and them not have Part B if it's required until July 1st.
Okay, Rhonda,
And
this is back to you. Yeah.
Yep, I want to talk about the selection process. So next slide. So once the patient has completed their evaluation, we have all the outside records that we need, which is usually their cancer screening. Then the coordinator puts them on the agenda to be discussed at committee. Committee is the first time that the entire team, the transplant nephrologists, surgeons, and the multidisciplinary team sit down and actually review the patient. Once the patient's reviewed, a determination is made and they're either approved and we put them on the list once we have final insurance clearance and their GFR is acceptable or they're on dialysis, then they're done and move to the wait list. If a decision is made to defer them, that's usually because there's either further testing needed, maybe the surgeons and the nephrologists, everybody discussed that they want more imaging of something that they saw, for instance, like a cyst on a pancreas, and they want something else. So just something to be completed. Or they're denied. And patients that we typically deny are for lack of caregiver, their coronary artery disease is too severe. We feel like the regimen is too complex for them. Once the committee is done, then and any of these determinations are made, a letter is sent to the patient, the referring nephrologist, and the dialysis center with the information. If the patient is deferred, then basically once they complete the items that was listed on the deferral, then they go back to committee to be represented and hopefully approved. Next slide. Oh, so once the patient's approved, put on the list, or a determination is made, and then they move to the waitlist team. And so next is Lisa Urban, who is one of our waitlist coordinators.
Lisa, you're muted.
Hello, can you hear me now? Okay, perfect. So once the patient is approved at selection committee, like Rhonda said, they are placed on the wait list, and their status at that point would be either active or inactive. Active means that they are able to be called for surgery at that point if there was an organ that matched them available. Inactive simply means that they are, it's a temporary status that just means that they're not ready for surgery at that time for various reasons. And it could be something medical, that we're waiting on additional testing. They could have a wait time based on possibly a renal cell cancer, a prostate cancer, things like that. It could be patient choice. They may have a living donor in workup. They could have fundraising, insurance problems. There's various reasons, but it is a temporary status. And anytime they're inactive, they are accruing time on the wait list. They're just not ready for surgery at that point. And once we get resolved whatever reason it is that they are inactive for, they can become active, and that does require another committee decision. As far as communication, we do send letters to the patient and the dialysis center and the referring provider anytime they are added to the wait list and with any status change. So whether they are changed to inactive or they were inactive and now they're reactivated. There are times when we need to remove patients from the waiting list for various reasons. And again, another letter would be sent if that were to happen as well. We encourage patients to always know their current status on the wait list and communicate with the transplant team if there are any changes to their health status. Next slide. Like I had gone over the common reasons for being inactive. One of them can be lab values, such as an elevated PTH. They do need to have that be below 1,000 in order to be active on the list. If a patient is having problems with that, once it does become consistently below 1,000, we do require those labs be sent to us so that we can review it. If there's any abnormal cardiac testing or waiting time for cardiac clearance, that's another common reason for patients to become inactive. If they have any elective surgeries, hip replacements, knee replacements, things like that, we'll make them inactive for that. Patient choice, I did mention living donors earlier, but also if they're traveling out of the country, or even if they're traveling somewhere in the country and they're just not able to get back for that time, they can be made temporarily inactive for that. And then as well as the psychosocial issues for caregiver, fundraising, those kind of things can also be reasons. Next slide. So once the patients are placed on the wait list, they are required to be seen by a transplant provider. It's depending on their age and their medical diagnosis, it can be anywhere from 1 to 3 years. Most patients are every 1 to 2 years. Some of our younger patients with the FSGS, IgA, or PKD are possibly every 2 to 3 years. And we do contact our patients annually as well. So while our patients are on the wait list, good ways that you can assist us and the patients is to encourage them to contact us anytime that they have any questions or concerns about their status. If there's any change in their medical condition, like they're admitted to the hospital, they have a visit to the ER, if they just started dialysis or they've changed from one mode to another, or if they've changed centers, we definitely want to know all of those things. We encourage them to keep their cancer screenings up to date. So that's the pap smear, the mammogram, colonoscopy. They are required to do those locally. If they've been done at Mayo in the past, we will sometimes continue that care, but typically wherever the testing was done prior, we encourage the patients to go back to that provider. We also encourage assisting arranging testing when a patient needs it done locally, if they need to have the echocardiogram repeated, if they need a stress test, or any of the cancer screenings. Sometimes they do need assistance with getting those scheduled. So, and also if there's any change in their address, their contact information, their caregiver, their insurance, those are all very important things that we need to know about that could affect if they were to be called for a transplant. We want that to be successful. So if we're not able to get a hold of them, or we find out that their insurance changed, or they no longer have a caregiver, those are all things that we need to know about.
All righty, we're on the anchor lap. So my job in the next few minutes is cover transplant and post-transplant. I think this is one of the take-home messages we need your help with, and that is the huge advantage that our patients get with living donor transplant. So our average wait for a deceased donor kidney will vary on blood type, but it'll be somewhere between 3 and 6 years. There's other parts of the country where it's significantly longer than that. So if they have a living donor, it's their fastest path to getting transplanted. It's generally done under ideal circumstances. Both the donor and the recipient are healthy and well, so it leads to less complications, shorter hospital stay, and importantly, most living donor kidney transplants last about 50% longer than the best of the deceased donors. So here, all of the patients are educated on living donation. They're also given some tools to try to tell their story. That can be in various formats. It can be at church functions. It can be at family reunions. It might be using social media, but we want to get the word out, and we're hoping that someone hears the story and is willing to give a kidney, because remember, let's skip to the next slide, the donor does not have to match the recipient. So not only do they not have to be a blood type, they don't have to be a family member, they don't have to have any tissue typing matching for them to successfully donate a kidney and result in that recipient receiving a living donor back. And the way that works is through this kidney swap or exchange program. So you'll see at the top, we have a donor that's not a match. It's incompatible, could be for blood type, could be for antibodies. Occasionally, it might be a viral mismatch, meaning the donor's been exposed to mononucleosis, the recipient hasn't. And if we did the direct transplant, it poses an increased risk of lymphoma for the recipient. So there's various reasons why the match may be incompatible. But what you see on the arrow, kind of in the blue turquoise kind of color, is that donor number 1 matches recipient number 2 that may be located in another state at another transplant center. And donor 2, who doesn't match recipient 2, matches recipient 1. And this is the simplest way, where there's literally an exchange of kidneys. The donors do not fly, the kidneys fly. So the surgery for donor 1 is done at Mayo Clinic, and the kidney flies to recipient 2. Could be local, it could be across the country. And similarly, donor 2 has their kidney removed at that other transplant center and flies to us, giving both recipients the advantage of living donor surgery. So living donor transplant can offer quicker access, and because the donor no longer has to match because of this matching program, and we're enrolled in National Kidney Registry, which is the biggest program doing these kidney exchange nationally, they brag that they can find a match in 80% of the patients within 1 year. So a much quicker and easier way of getting transplant. Next slide, please. So not everybody is lucky enough to have living donor. And what we do is educate our patients on alternative deceased donors that we would strongly encourage them to consider to get transplanted quicker. Although each of these kidneys poses minor risk, the benefit of getting off dialysis, getting transplanted quicker, far outweighs any of these risks. So the other assistance we need is kind of providing accurate information to our patients so that they can routinely consider these options. And hopefully, if there's any doubt and whether that's a good match for the patient, please reach out to us. We may be able to provide education of why the benefit of a hepatitis C kidney or a KDPI greater than 85. So this would be, I'm an old man, this would be someone my age. If I die tonight in my car ride home, my score might be 85. And what that's telling you is the 66-year-old version of my kidneys isn't going to last as long as the 25-year-old version of my kidneys. And then remember that even donors that die in jail, they die of a drug overdose, they can be considered as wonderful donors. And the reason is if they test negative for HIV and hepatitis, although that risk may be higher than my risk tonight, if I have that car accident and my wife swears I'm an angel, I still have a small risk of transmitting HIV and hepatitis. If my wife says, oh no, he's a drug addict, that risk goes up, but it's still incredibly low for these patients. And we believe that the medical advantage of the transplant far outweighs any of these risks. Next slide, please. So we do our best. Lisa kind of hit the nail on the head that we do our best. Any kind of change that we make, we try to make some type of communication. And a lot of it is documented in writing. We also try to use the phone to communicate. We've recently started using electronic communication, not only for the intake process, but for our waitlist management. If they sign up for it, they may get a text message asking them a number of questions. For example, have you been in the hospital? Have you developed recent infection? Have you changed insurance? Have you had a change in your dialysis or dialysis center? All of this is very important information for us, not only when they come back for a health update so that they get the care they need. If they were on peritoneal dialysis and they're now doing hemo, we need to know that to schedule the hemodialysis visits while they're here. But it also helps that when we call them in for transplant, they're less likely to be sent home without a kidney. So this type of communication between your team and our team is critical. We are trying different ways, directly reaching out to the patient, but any kind of information sharing will be beneficial to all of us when we deal with these folks. Next slide, please. So this really is a partnership. And there's several reasons why we want to grow and strengthen the partnership. And what we're looking at is describing our workflow, but just as important, we want to hear opportunities to help you with your workflow, because there will always be the possibility where they don't mesh, but there may be an opportunity to make the meshing occur so that it saves each of us time, effort, and it's then better for our patients. So whether you have a question about the kind of medical or workup, the insurance, the financial aid, the caregivers, the transportation, or whether it's specifically to deal with medication or communication with your team, please feel free to ask us today or reach out. The next slide, I believe, if you don't mind advancing, has contact information. So that's the referral phone number and email. Pat's been very kind in answering a lot of these, or at least kind of triaging any request for information to the proper member of our team so that you get the information that you need. And then you have contact for our financial coordinators also. So the next slide, please. There is a recording of this webinar. We've done 2 other webinars. They are available to you. You can either use the QR code, which Pat has shared with you all, or that little link, the bit.ly link is where we store these, and they're available then 24 hours a day. The next slide, please. We want you to get credit for your CEUs, And this is what you'll use, either this link, so bit.ly 45M8LX0. I hope that's what that is. Could be an I. And or the QR code would be a wonderful way of getting credit for this activity. And the next slide is the questions. So I'll turn it over. I think Natalie was going to kind of help guide us through some of the Q&A that you guys have included, and we're happy to answer questions if you think about them now. Thank you.
Awesome. Well, thanks to all of our panelists. I know we covered a lot of content, and I see several questions have come through the Q&A, so appreciate that. And we'll go ahead and start with the first question here. So the first one is, are there any financial assistance programs for travel and lodging?
Okay, so I'll take that one. And if any of you are coming in from Georgia and you do not know about the Georgia Transplant Foundation, that needs to be your homework for today. They are the best organization that helps those Georgia patients with travel and relocation expenses, transportation. They will help with lots and lots of stuff and have wonderful programs. So if you're not aware about Georgia Transplant, become aware about Georgia Transplant. So we are working, we don't have a lot of other programs available to help with the travel and the lodging. So the travel, we are currently working, Southwest Airlines, I think is helping us to come up with a grant to try and help some of our patients. So we are currently working on that. And then just this week, I found out TRIO, the Transplant Recipient International Organization, also has some kind of program with United Airlines. So we're starting to look into that too, and we'll look at some of the other airlines too. When you're here, Gabriel House of Care, which Dr. May is on the board for, they're also a wonderful they're our hospitality house here on campus. It's a wonderful house. They only have 29 rooms, so you have to kind of call ahead. But if patients want to stay there, we can give cards out that tell you how to get a hold of them, and they can call in advance and see if there's if there's space available. Georgia Transplant Foundation is a direct bill facility with them too. So Georgia Transplant will pay for them directly. So hopefully that answered most of that.
Thank you, Pat. And Gabriel House, if I didn't hear you mention that, is located on Mayo Clinic's campus. All right, we'll move on to the next question. Is the process for kidney transplant the same at all Mayo Clinic locations? Dr. May, do you want to take a stab at this one?
Yeah, so from a medical perspective, there is actually regular meetings that happen every 2 weeks between the Arizona, Minnesota, and Florida campuses. And there is incredible convergence on the protocols. So the important thing we've shared with you, kind of when you refer a patient, and that is the same at each of the 3 institutions. With regard to financial assistance, Pat spoke that we're looking at opportunities. Currently, both the Minnesota and the Arizona campuses have access to funding that we currently don't have in Florida, making that a little easier to help their patients. We're looking at ways where that can be provided on this campus also. So there are some minor differences, but for the most part, it's the same process at all 3 campuses.
Great. Thank you, Dr. May. And this next question, I'll have Erica. So can you repeat the explanation of the Medicare Part B coverage for the immunosuppressant drugs after 3 years? If recipients lose Part B, do they lose coverage?
No, there's a immuno bill that passed in January of this year that allows a patient to continue getting their immunosuppressive drugs covered under their Part B, whether they are not age eligible or they're on disability, and they still remain with their immunosuppressives covered under their Part B. And it's that way for the rest of their life because of the immuno bill that passed in January. They've been trying to get it passed for a really long time. And now it has been. There was issues with the reason why they wanted to pass the bill is because there are so many patients that had Medicare for their transplant, and then after 3 years, they were having issues getting their immunosuppressive drugs because they're really expensive. So it passed in January, and so their immunosuppressive drugs will be covered under their Part D for the rest of their life.
So if I can jump in on this, we were all really hopeful about this immuno bill. It's ended up not being quite as good as we all hoped. The one caveat for the immuno bill is that you have to have no other insurance options, and that includes the marketplace. So really, it's affected very few patients. We're finding on the back end, which is kind of a shame because it took them 10 years to pass it. So I think we had bigger hopes for this, but so far it's not helping as many patients as we thought that it would. So
Thank you, Erica and Pat. So the next question that's come through, is there a geographical boundary limit for patients? In other words, does a patient have to live within a certain boundary to qualify for listing? One attendee mentioned they have a patient in California interested in coming to Mayo Clinic, Florida.
Yeah, I'll take that. So no, there's no boundary for folks. They can live in Puerto Rico, they can live in Mexico. Once you start getting further away, like Alaska, you get overseas, then it's harder to wait at your home for a transplant because it's almost impossible to get here in time to get the kidney. So I think for the California patient, I will point out that Arizona has equally short times for their transplants, and they actually have a few blood groups where they are faster than we are because of the volume of kidneys that they do. So if they're interested in Mayo Clinic, we're happy to see them in Florida. I will also tell you that if you get listed at any of the 3 Mayo clinics, you can automatically or nearly automatically be listed at the other 2. As I mentioned, because we share the same protocols, in general, if you're approved at any of the Mayo clinics, you should be approved at all 3. So there would be a very rare exception where that wouldn't work. But in general, that does. It's called multi-listing here, and it's a service that we offer for any patient listed at any of the 3 clinics.
Excellent, thank you. And I see a question related to the recording. I'll let Pat answer that, but is there a way to view the recording? I'm sure Pat will be sending it out, but I'll let her take this one.
yeah, I will. I just moved back to the slide about the social work education that we have out there. We specifically created this playlist under the Mayo Clinic YouTube channel to help you guys because we know that the turnover is high for the dialysis social workers. So we want you to be able to get these whenever you need them or whenever you have new staff. So this video recording will probably be out there within a week or so. I do have to edit it a little bit and fix the closed captioning and get it uploaded. But if you scan that QR code, and after this, I will send everybody who's on the meeting, I will send a copy of the presentation and this flyer for the video link. Okay, so that you can always have that. I want to add one other thing while I'm on here is we have a wonderful new thing rolling out here at Mayo, the microsite projects with the with the NKR. And I tried to get social work credits for that, and I cannot get social work credits. But NKR is willing to do a presentation for us with the dialysis social workers. So we will probably try to do that in the next couple of months, probably November or December. And I can't offer you CEU credits, but at least you'll get some idea of what that is. And it's a very good program that's offering our patients their own basically website to funnel donors through. And it gives them ways to share that website information and somebody to help them develop that website. So more to come on that.
Thank you, Pat. Next question, is there any patient assistance for patients with only emergency Medicaid?
Okay, so for kidney, and Erica, you might want to jump in here too. For kidney, we don't actually accept Medicaid as the primary insurance here for transplant. Erica, you want to jump in on any more of that?
Yeah, that's correct. If they don't have insurance, or like you said, if it's emergency Medicaid, they can always go to our website and see if they would qualify for front-end charity assistance. If it is, say, it's Georgia Medicaid or Florida Medicaid, the patients wouldn't be eligible for charity assistance on the front end. They would have to go to a facility that does take their Medicaid for transplant, even in Florida.
Thank you, Erica and Pat. I know we're getting close to time, so we'll try to get through as many questions as we can. And if not, we can certainly follow up after, or you feel free to contact Pat or any one of us to answer those questions. The next one I see that came through, are we requiring the COVID vaccine? Here in Florida, the answer is no, but I'll let Dr. May comment on some of our other sites.
Yeah, so Governor DeSantis won't allow us to require any kind of COVID vaccine for medical care, but the other two Mayo clinics do require COVID vaccination to be active on their transplant list. So it's a mixture out there for transplant centers. I don't know if it's 50-50 anymore, it may be less, but there's still quite a few transplant centers that see value in being vaccinated, given that the transplant recipient is at much higher risk of dying of COVID than the dialysis patient. And of course, both groups are at much higher risk than the general population. So although the vaccine may not be as effective in transplant recipients, it still makes sense to do it. And we encourage everybody to get up to date. So with the recent release of the new vaccines, we would encourage the one-time booster vaccine, but it's not mandatory at Florida. It will be at Arizona and Minnesota.
Great, thank you, Dr. May. And while we have you, there was another question about the wait time for deceased donor transplants. So can you comment on what that wait time is again?
Yeah, so as I think has been pointed out, you will get wait time credit from your dialysis start date. So that's important. There's a new project regarding some of the race neutral GFR equations that were used to determine kidney function. And so for the African American recipients, they will have a careful review of when their GFR exactly hit that target, and they may be able to actually get wait time credit even before their dialysis date. So be aware of that. That's a big project that every transplant center is supposed to complete by January 1st. But the key is the number is 3 to 6 years. So blood group A, blood group AB is generally around a 3-year wait. Blood group B and blood group O are in the 5 to 6 year wait. And as I mentioned, hepatitis C kidneys, KDPI greater than 85, donors that meet risk criteria for HIV hepatitis can save anywhere from as little as 6 months to as much as almost 2 years off that wait if they're willing to accept those type of donor kidneys.
Great. Thank you, Dr. May. And I know we're at time, so we'll take one final question. And I saw a couple questions come in about the referral links. So if you have an account with CareLink, you can send any referral to any one of our Mayo Clinic sites. Same goes for the online form that we listed from a patient's perspective. The fax and phone numbers that we listed are, however, only specific to the Mayo Clinic Florida campus. All right. Well, given we were at time, I want to thank you all for joining and for the engaging questions. And we really, really appreciate your time. And I want to thank our panelists for joining today and taking the time to share some of this information. So thank you all very much and have a great rest of your day.
Thank
Bye,
you.
guys. Thank you.